Hey everyone, Tom here with Move. Welcome to this presentation on acute ankle injuries. Before we begin, just a quick disclaimer that this presentation does not constitute medical advice, and all of the information provided is targeted towards junior or early career clinicians in the private practice setting. Okay, so moving on from our previous presentations, now we're talking about the assessment and examination of acute ankle injuries in particular. And the approach to diagnosis follows the same algorithm that you all would have been taught, but would like to encourage moving forward is to take a thorough history, and then moving on to your objective examination, you go through the process of look, feel, move, special tests, and then ordering appropriate investigations as you need to. Touching on the important aspects of the history component for an acute ankle injury, I can't emphasize enough how specific you can be with the mechanism of injury for ankle injuries and how useful that information is to make an assessment as to what the underlying structural diagnosis will be. You'll see the image down here. This is of Jake Stringer, has a classic forced abduction of the ankle and forced eversion, which is pathognomonic for a high ankle sprain or a syndesmosis injury, as it's otherwise known. That's very different to the common mechanism for a lateral ankle sprain, which would be inversion, and is invariably a less significant injury than that of an eversion injury. So anytime someone tells you with some certainty that their mechanism was eversion, always be more suspicious that a more significant injury has occurred, either in syndesmosis or an acute fracture or fracture dislocation of the ankle in more severe cases. The other one to be mindful of in terms of the three common mechanisms would be the high energy or axial loading mechanism. So this is more someone who's fallen from a height down onto their feet, or someone who has been in a head-on car crash and there's been force transmitted through their feet. That's more likely to be a talar dome type injury, or you can have osteochondral lesions of the talus as well. But it's a different mechanism that we don't commonly think of that I think is worth being aware of. Back onto the remainder of the history, another key component is can the person weight bear or not, and that goes for can they weight bear immediately at the incident, or can they weight bear 4 steps when they present to you. Previous history is really important here because we know that lateral ankle sprains commonly reoccur, so you can be quite confident if someone's come with a good going history or mechanism for a lateral ankle sprain and have had one before, that's most likely what you're dealing with. Keep in mind whatever associated symptoms a person might be presenting with can give you very valuable information. And this is more looking at the not to miss diagnoses. So is there some evidence of neurovascular compromise? So they're presenting with paresthesia, or is there some trophic changes to their foot? It feeds into how you should assess that person as well. So you're checking their sensation, what's happening with their tibial nerve, deep peroneal and superficial peroneal nerves, and can you palpate their pulses as well? A deformity will give things away in terms of is there an acute fracture or dislocation, and then you're looking for instability as one of the key symptoms with most common ankle injuries too. Over to the examination now, and we're going back through that look, feel, move, and special tests algorithm. Let's move myself out of the way here. We've talked about a couple of things that you can think about when looking at the person in front of you, but always assess whether or not they can weight bear or move comfortably. Palpating the key areas that are associated with fracture, so the lateral and medial malleoli, base of the fifth met, the navicular bone, and then along the talocrural joint line is important too. The key ligaments are lateral ligaments and syndesmosis, and then deltoid as well. And then active range and passive range of motion is important, but not the most crucial thing that you'll be dealing with in these situations. Finally, thinking about special tests, most of you will be familiar with the lateral ligament cluster, so your anterior draw and your talar tilt for ATFL and CFL respectively. The deltoid ligament, less common and is more associated with that eversion mechanism, but you can do an eversion stress test. Syndesmosis injuries you can assess with the Kliger's test or squeeze test, and then Liz Frank test. There's a number of special tests that you can do, but a giveaway is often the plantar ecchymosis that you can see in the top picture there. And don't be the person who forgets an Achilles tendon rupture as a differential. Okay, we'll see you next time.